Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Right, hi David, we're back. Nice to see you.
We're back. It has been some time. It has.
And you've had a baby.
I've had a baby. You've also had a baby.
That's right. Yeah.
Not the same baby, just for clarity.
Yeah. So hopefully 2 new budding haematologists on their way.
Woe betide.
Good. So yeah. Sorry, we've been a bit absent. It turns out having a baby is more work than we both thought it would be.
Yeah, I'm still in the thick of it. So if I sound stupid, can we blame the baby, not my lack of knowledge? That'd be great.
Definitely. Okay, so today I thought what we would do is we're going to move into doing a lot on clotting and coagulation, all things clotting over the next few months. But the first place to start would be just to look at a clotting screen and really the basics of haemostasis. And kind of touch on when it's right to do a clotting screen, when it's not right to do a clotting screen, what it can and it can't tell you, and then we'll finish with maybe a clinical case or something.
Yeah, that sounds really good. I think especially in clinical practice, the amount of times you're asked to do something, do a clotting screen, do an INR, and then you get a result, and then you're like, oh dear, I don't know what this is. And then some poor haemareg gets called. So I think it'd be useful to have at least a little bit of knowledge to fire back before you sort of,
definitely. And whenever you're studying clotting, a website that I really recommend is Practical Haemostasis. It's really good at going through the lab tests so that you can understand a bit more. I mean, we will be going through practical haemostasis in a separate podcast, but it's a really good website and a really good resource. Good. Okay, so why don't we start with the basics of haemostasis? Like, what is haemostasis? Can you break it up into different stages that you might be aware of?
Yes, I'm just trying to think here. So I guess haemostasis is a challenge has happened, whether it's been sort of an injury or a cut or something like that, or you're I don't know, there's a deficiency somewhere. But there's multiple layers. There'll be the platelet side, there'll be the vasospasm, so there's sort of the vascular side, and then I guess the bit we're really interested in today is the sort of the clotting side, the coagulation, and that's sort of broken down sort of, I guess, esoterically, academically, into an intrinsic pathway, an extrinsic pathway, and a common pathway. Okay. Although I'm going to pick your brain a bit later about whether that's actually something that happens, because through a bit of reading, sort of people say, yes, these are things that we talk about, but in-vivo, which I think is code for actual real life, those things don't it's too hard to unentangle.
Yeah, definitely. You're right. So I would kind of think of haemostasis in terms of 4 stages. So primary haemostasis, secondary haemostasis, then sort of regulation of haemostasis. So that's control of clot formation, both in terms of where and when, so that we don't just clot off our entire body. And then fibrinolysis, so dissolution and remodeling of the clot at the end when its job has been done. And haemostasis, it's interesting that you say that we're most interested in the clotting part of it, because I guess you mean like the coagulation cascade, like the clotting factors in the blood. But that's a common misconception. That you're right. You've already kind of drawn on something, which is that a lot of people think of haemostasis as clotting, but that's just one aspect of it. So do you know what the difference is between primary and secondary haemostasis?
Let's say no. Let's go with no.
That's fine. No. So So primary hemostasis is basically the initial platelet plug that is formed. So when we have sort of damage to a blood vessel, the initial thing that needs to happen is the platelets need to basically become activated. They need to be tethered to the blood vessel where it's damaged. And then they need to become activated and degranulate and stick together to basically form your initial primary hemostatic plug, which basically consists of activated platelets that glue together. And and that involves things like the vasoconstriction that you were saying about as well. And it involves things like von Willebrand's factor, which we will do a whole separate podcast on, to allow the platelets to adhere to the damaged area, and then the formation of this plug. And if you have a problem with primary hemostasis, so we haven't even talked about the clotting system yet, that hasn't even got involved. But if you have a problem with the primary hemostatic process, do you know what kind of clinical picture that creates?
I'm trying to think. So is that a sort of our like big bruising, our purpura and sort of petechial kind of situations?
Yeah, and it's mainly mucocutaneous bleeding. So think of your kind of classic patient on, I don't know, aspirin or something, where they've got a problem with their platelets because we've given them a drug. So it's mucocutaneous. So this is things like hematuria, menorrhagia, GI bleeding, epistaxis, and as you say, petechial pattern and bruising in the skin. So can you think of any causes of a sort of primary hemostatic problem?
So to my head, drugs, as you mentioned, I
Yeah,
think we make a lot of the problems.
yeah. So
Um,
antiplatelets, yeah.
I wonder if there's any sort of acquired sort of anti-platelet problems, so
Okay.
or like cell-mediated ones.
Um,
Um,
okay, yeah. Yeah, I mean, I guess there are acquired problems with your platelets, like in renal failure, a high urea can cause problems with your platelet function as well. Yeah.
and then I guess genetic problems with your platelets and
Yeah.
activation.
Okay.
Um, and I guess we mentioned von Willebrand's as well.
Yeah,
So
exactly. Yeah. So,
um,
yeah.
yeah, carry on.
No, I was going to say, I mean, the way I think about this is just think about the process that needs to occur. So you need to be able to have, your vascular endothelium to become activated and there to be damaged. So connective tissue disorders can cause a sort of primary hemostatic problem type picture. So things like you can get a sort of bruising petechial type picture in air loss, Dan loss. Things like hereditary hemorrhagic telangiectasia. Some vasculitides cause a petechial rash. Then you've got your platelets that need to be able to adhere to the endothelium and stick to each other. So you've got a platelet issue that can cause a primary hemostatic problem. In particular, that's number of platelets. Don't forget just your thrombocytopenia. Then you've got your function of your platelets, which, as you say, can be acquired, for example, in renal failure, for example, and then also your antiplatelet drugs. And then you need your ability of your platelets to both be tethered to the blood vessel wall as well as glued to each other. So that's where things like von Willebrand factor and von Willebrand's disease come in. Yeah. So that's your primary hemostasis, sort of in a general nutshell. So then on the basis of that, what do you think might be secondary hemostasis?
So there's a lot of activation factors in platelets, isn't there? And the dense cells, they have sort of things that set off your coagulation cascade. And I imagine that's our secondary is a coagulation cascade that results in cross-linked fibrinogen at the end. Or
Cross-link.
fibrin, sorry.
Yeah,
Yeah,
exactly.
close.
Yeah, close but not right.
Yeah,
So
yeah.
yeah, so basically for your secondary hemostasis, that's the process where you have formation of fibrin to basically form a more robust secondary hemostatic plug. So you've got your initial platelet plug, but that's easily dislodged and can cause bleeding. And so without your clotting cascade being activated to create basically thrombin, which converts your fibrinogen into fibrin, and then your fibrin can then kind of mesh together and basically make this really good, robust secondary hemostatic plug. So that's where clotting and the clotting cascade comes into in secondary hemostasis. And what kind of pattern of bleeding is typical in a secondary hemostatic problem?
It's that sort of deep joint problems.
Yeah, exactly,
Yeah.
exactly. So just think of your haemophilia patient. So your patients with haemophilia, they get deep bleeding patterns, so bleeding into joints and into deep muscles, for example. And so causes of secondary hemostatic problems.
So I guess the hemophilias,
Yep.
um, A and B are the ones that I mostly come across.
Yes. Yep.
um, von Willebrand's disease. I should
Yep.
think anything to
Some
do with
types of von
vitamin.
Willebrand's, but only really type 2N, because effectively it's reducing the amount of factor VIII that's in the body. Von
Okay.
Willebrand's factor really has a role in primary hemostasis rather than secondary.
Okay.
Yeah.
And then vitamin K deficiency, and then I guess anything to do with synthesis, so liver problems.
Okay, yeah, so we'll come back to all of those things, but yes, any problem that's acquired that causes you to have lower levels of clotting factors than you would normally have. And then, of course, anticoagulants as well, like warfarin and that kind of thing.
Yep.
Yeah, excellent. So that's the whenever you're thinking about a patient in terms of their bleeding risk, make sure you're thinking about the four stages, and in particular the primary and the secondary hemostasis to start off with. So then you mentioned the clotting cascade. Would you like to talk me through the clotting cascade? Or
Not
would you like
really.
me to talk you through the clotting cascade?
So, you're probably better off going through it. But
Yeah.
as I sort of suggested, there's an
Hmm.
intrinsic pathway that sort of, I think, starts off with factor 12 and sort of heads on down towards factor 10, which I think is
Yeah.
where they all sort of coalesce. And
Yeah.
the intrinsic pathway is from, is it factor 3? I can't remember. But they all converge on the sort of the factor 10, and
Okay.
that sort of leads to our thrombin, prothrombin being converted to thrombin, and
Yeah.
then that converts our fibrinogen to fibrin. And
Okay.
then there's a lot of complexities in there, which I'm scooting over as if
That's fine. No, no,
I
that's
can
fine.
recall them offhand.
So, okay, so I guess the first thing to say about the clotting cascade is for our listeners at home, if you're not driving a car right now, I would probably go on Google Images and just get up a clotting cascade. And I'm just doing that now. There's plenty of diagrams there. Click one and have a look at it as we talk through it. But essentially, and David, you're just going to have to picture it for the time being, and anyone who's driving a car or doing something else. But essentially, the clotting cascade is actually really easy to learn because your factor 10, as you say, is in the middle, and that's like kind of X marks the spot, and it's where the two pathways converge. So you've got your common pathway, which is basically factor 10, which, with the help of factor 5, activates 2, which is your prothrombin, into your 2A, which is your thrombin. And then your thrombin converts your fibrinogen into fibrin. And the fibrin is then what cross-links your platelets and makes your secondary hemostatic plug. So from 10 down to 2A, that's your common pathway. Okay, so both of your clotting pathways converge on the common pathway. And both your PT and your APTT, which we'll talk about in a bit, but they're two of our main clotting screening tests, both involve or include measurement of that common pathway. Okay. And then you've got two pathways feeding into that factor 10, that X marks the spot in the middle. So you've got your extrinsic pathway, which is your tissue factor and your factor 7. And so where there's damage, you get your tissue factor release and you get your factor 7 gets activated into 7A, and then that directly goes to 10. So that one's quite easy. It's quite short in terms of the number of clotting factors. And then on the other side, you've got your intrinsic pathway. And your intrinsic pathway, as you say, starts with 12. And then there's a nice, easy way to remember the numbers. So 12 ends in an E, so then E for 11. And then 11 ends with N, so N is for 9. Then 9 ends in E, so then that's factor 8. And then that goes on to 10, which X marks the spot, it's in the middle, and that's then your common pathway again. Does that make
That,
sense?
that is lovely.
Yeah, it's nice.
I'm genuinely just that's going in the bank. We'll take that.
Okay. And then in terms of understanding then what our clotting tests are measuring by looking at that clotting cascade, the prothrombin time is measuring the extrinsic and the common pathway. So therefore it's factor 7 and tissue factor, and then 10 to 5 and basically to the formation of a clot. And then your APTT is measuring your intrinsic pathway and your common pathway. So that's 12, 11, 10, I mean, it's 12, 11, sorry, 9, 8, and then 10, and then going down to your common pathway. Okay. So once you understand what those two clotting tests are measuring, using the clotting cascade, you can then begin to understand how those two tests are affected by deficiencies in various clotting factors, and that can be really helpful. Okay.
Yeah, so I'm just from what you're saying, it sounds like having one of those in isolation, just a PT without an APTT, is useless.
Yeah, it depends why you're doing it. So we will come
Okay.
back to that and we will park that because I would say any clotting screen blood tests are totally useless outside of the clinical context. Okay, they are not, and what you have to keep reminding yourself here is what was the PT and the APTT actually designed for. So do you know why we even designed a PT?
Oh, no idea.
It was to measure. It was to then calculate the INR to measure warfarin. It's purely been developed for warfarin monitoring.
Okay.
And the APTT was purely designed for heparin monitoring. And somewhere along the way, these blood tests that have been designed to monitor effects of drugs have morphed and evolved into people understanding them as, oh, that is the patient's bleeding risk. But it's not the
I,
same at all. And it was never
I
designed to
can feel
be.
your blood boiling here. I
It's
feel
not
like
boiling, it's just like yeah, somewhere along the way, people have forgotten what these tests were designed for, and as a result, are no longer appreciating what they can and they cannot tell you. Now, we've just gone through the clotting cascade, and that's lovely and that's really useful for exams. And I'm a big fan of the clotting cascade represented in that way because it really helps me to understand what might be affecting these lab tests, okay, which I can then interpret in the context of the patient and what's going on. However, just to burst that bubble, pop, okay, actually, one of the big things I had at med school was okay, well, if there's this intrinsic and extrinsic pathway feeding into the common pathway, then why do haemophilia patients, patients with haemophilia who've got a factor VIII deficiency, why do they bleed? Why can't they just upregulate their extrinsic pathway, for example? Because if you've got these
yeah,
two
yeah,
pathways that feed into the common pathway, like,
yeah,
why are they getting such bad bleeding?
yeah.
And the reason is because actually in real life, of course, this paper version of what happens with activation of the clotting cascade is obviously totally not linear in terms of intrinsic and extrinsic feeding onto a common pathway. We haven't taken into account the platelets and the surface of the platelets because a lot of this clotting cascade occurs on the sort of externalized membranes of the activated platelets. And you're not taking into lots of other sort of things that will affect that clotting cascade. But even more importantly, someone drew me this diagram and it sort of blew my mind. But actually, the clotting cascade doesn't in real life kind of exist as two pathways feeding onto the common pathway. What probably happens, or what's more like what happens in real life, is you have initial damage which causes tissue factor release and factor 7 activation. Okay, so the extrinsic pathway in inverted commas. And that causes initial thrombin production. And then that thrombin production then has a positive feedback. And the thrombin, yes, it converts fibrinogen into fibrin and forms, the initial fibrin of the secondary hemostatic plug. But it also goes back and has positive feedback on factor 5A. It also causes dissociation of von Willebrands from factor 8 so that can become activated more. It also increases your levels of factor 11. So actually, there's this massive crossover where the initial thrombin that's made to tissue damage via the traditional extrinsic pathway is then going and ramping up all other aspects of the clotting cascade, including that intrinsic pathway. And then what happens is it allows you to form the 10A's complex, which is a bit of factor 10, bit of factor 8, bit of factor 9, that kind of exists as this big raft and allows a massive production of thrombin. And so you can think of the initial production of thrombin through that traditional extrinsic pathway as like an initiation stage. And then you get all this positive feedback by that initial thrombin to create then a thrombin burst, which is the amplification kind of propagation phase of clotting, which is why there's a bit of a lag. And then suddenly it's like wham. And so in haemophilia A, for example, where you don't have factor 8, you can't get that thrombin burst. You get the initial thrombin generation, but you can't then sort of ramp it up in the same way and get that propagation amplification phase. And that's why they get, in reality, much more profound clotting than you would otherwise expect from a very linear kind of representation of the clotting cascade. Does that make sense?
Yeah, I don't know for sure. I
Yeah.
think that's a problem with human thinking as well, isn't it? We're very good at linear thinking.
Yes.
We could, if you ask someone to add 8 + 8 + 8 + 8, they could probably do it pretty quickly. But it's
Mm-hmm.
exponential thinking. If you were like, can you times 8 × 8 × 8 × 8?
Yeah.
You've got no
Yeah.
chance.
Yeah,
I think
exactly.
we're just not wired to think like
No,
that. So
exactly.
you're like, if I've
Um,
got two factor sevens, it makes two factor eights and two factor nine. It's that
yeah.
sort of
Yeah,
process. So yeah.
exactly. So, but I'm not knocking the clotting cascade in terms of the lab representation. I think it's still really useful for us to understand, but just remember that this is not what it was designed to do. And on that note, something that also I thought was really interesting is that do you know how much kind of factor you generally need to maintain hemostasis, generally speaking, as a percentage?
I wouldn't be able to quantify it.
Fine, no,
Literally no
that's
idea.
fine. So
Yeah.
basically, if I have basically, if you want to maintain normal hemostasis, you probably need about 50% of what's deemed kind of normal before you might run into kind of bleeding problems. So what and that is again deliberate in that we just calibrated our PT and our APTT such that you have to drop to 50% of kind of normal levels of factor before that causes prolongation of that test. Does that make sense?
Yeah.
It's been calibrated to that. So again, well, it's just a useful kind of side note, really, but it makes you realize that you don't have to have 100% factor for it to cause a bleeding problem. There's like quite a lot of backup built into the system. Okay, so on the basis of what we've discussed with the clotting cascade, then I think it can be really useful to help us to understand and interpret a clotting screen more easily. So I like to think about a clotting screen in terms of knowing what the causes might be for an isolated prolonged prothrombin time, an isolated APTT, and then both of them being prolonged and what the different causes would be of them. So if we start with an isolated prothrombin time, what factors might make just the prothrombin time prolonged?
So just offhand, I think factor seven.
Yeah.
I'm trying to work out which other ones would be affected without affecting the common pathway, and it
Yeah.
feels like just factor seven. So either a deficiency or an antibody.
Yeah, okay, good. So antibody against factor seven is going to be quite rare.
Yeah.
Deficiencies of factor seven. Factor seven is actually something that goes down really quickly compared to all the other factors. And the reason for that is because it's got the shortest half-life. So if you think of somebody who, for example, takes a paracetamol overdose, one of the really important tests in that situation is an INR or a PT, because it's one of the most sensitive tests for looking for the clotting going off from acute liver failure. Because factor seven has the shortest half-life. So if your liver suddenly stops making all your clotting factors, the first one that's going to go down is factor seven because it doesn't hang around for as long as the others. So yes,
That's really interesting. I'd always wondered
yeah,
why INR was the big one that they wanted. So there we
yeah,
go.
yeah.
Mystery
There you go.
solved.
Yeah, yeah, exactly. And so basically, what clinical causes do you know of that can cause a low level of factor seven? Obviously, we've talked about an overdose in liver disease.
So I guess anything else that affects synthesis of the so I guess some kind of a liver injury or an
Okay.
ischemia.
Okay.
I guess there's also dilutional factors if they had massive transfusions.
Okay. So I like what you're suggesting there, David, but all of those suggestions are probably going to prolong both.
Yeah,
Because
I was trying to work out because it
yeah.
has the half-life
And
whether
I probably
it
put you off
limited.
there because I was talking about acute liver injury. So acutely, the INR will go off first, but in liver disease, both are going to go off,
Okay.
most likely. I mean, normally the INR is still more sensitive to a coagulopathy secondary to liver disease than the APTT because you can release factor VIII from other places that doesn't necessarily need the liver. But still, that, in liver disease and in a dilutional coagulopathy, you're going to dilute more than just your factor 7, for example. So that's going to prolong both. So your isolated prolonged PT, you're really thinking about vitamin K deficiency. And so causes of that are things like malabsorption. So if you've got really bad inflammatory bowel disease, also if you've got a cholestatic jaundice, because your vitamin K is fat soluble, so it really needs that system to be working. And then poor diet, if you're an alcoholic and you're only drinking alcohol, you're not going to be getting your your vitamin K intake in, and so that can cause you to become vitamin K deficient. So, and then of course warfarin, and your other coumarins. And then you could also there are congenital factor 7 deficiencies as well. So that's also a cause potentially of an isolated prolonged PT. But you're basically thinking about vitamin K deficiency. Okay, what about causes of an isolated prolonged APTT?
So our haemophilias are in there.
Okay, yeah.
Haemophilia A and B.
Yep.
I
So
guess
that's
because
factor 8 and 9 deficiency. Yep.
Yeah, and because it's a factor 8 area, I guess von Willebrand's disease is also
okay, good.
a problem.
Yeah, because of the von Willebrand factor's role in normally carrying factor 8 around in the blood. So in particular, that's going to be your type 2 N for no factor 8, because that's particularly the type of von Willebrand's where your von Willebrand factor can't carry factor 8 because of where the mutation is at. And your type 3 von Willebrand disease, which is very severe, so that again, you've got a much shorter half-life of your factor 8 so that they get low factor 8 levels, yes. And then other causes of an isolated prolonged APTT.
So isn't it things like an inhibitor? So a lupus anticoagulant?
Good. Yeah.
I'm not sure. Don't ask me why. I know the first answer. I don't know the second. You'll be like, why is that, David?
No, I'm not going to ask that because that's beyond the scope of today. But we are going to do a whole podcast on antiphospholipid syndrome. But in short, lupus anticoagulant cause a prolongation of the APTT because they bind to phospholipid, and so therefore they affect our lab tests. They do not reflect a true bleeding risk. They're actually, if anything, at risk of clots. And then any other inhibitors you know about?
Not that I can think of.
Okay, well, there's also this condition called acquired haemophilia A, where you basically make an autoantibody against your own factor 8. It's usually paraneoplastic for someone having cancer, and they present with bleeding. But again, we'll cover that in a different podcast. Okay, we've done isolated prothrombin time, isolated APTT, and then what might prolong both then? We've already said liver disease and a dilutional coagulopathy like in major hemorrhage.
Consumptive? So something like DIC?
Exactly. DIC is a big one. And if you see both clotting tests being prolonged, then you definitely need to know the clinical context. You need to be looking at the full blood count to look for, thrombocytopenia, maybe an anemia as well. And you need to be looking at a Klaus fibrinogen and looking at how sick the patient is and thinking about the differential. And any unwell sick patient can have a prolongation of both tests. So and that can be through a combination of different mechanisms. Okay, great. So you can see how the coagulation cascade and understanding what the APTT and the PT roughly measure can help you with working out why someone's clotting screen might be abnormal. But now I'm here to kind of be the person who's now very anti it and say, hey, there are loads of limitations. And I guess my biggest question to you in this whole podcast, and the biggest point that I want people to take away from today, is what do you think is the best test for a bleeding risk for a patient? Do you think it's the PT or the APTT? Or do you think it might be something else, David?
This feels very biopsychosocial from medical school. I imagine it's the clinical history is the most important test.
I'm so glad you said that. Okay, and that is so true. The best clotting screen test you can do is the history. Okay, I cannot repeat that enough. The PT is not the best test. The APTT is not the best test. The Klaus fibrinogen is not. It's the history. what things in a history are going to make you wonder whether someone might have a bleeding problem? Let's say you're seeing them in a pre-op clinic or you're about to do a procedure on them. What questions would you want to ask?
So a thorough medical history, and I'd like
Okay.
to know what medication they're on as well.
Okay,
Whether
so
they're,
drugs, yeah. Drug history.
um, I guess their demographics are kind of important. Whether I guess when they're getting older, their chances of their sort of their ability to produce all the clotting factors is going down. And I guess
Okay,
if
ish.
they're yeah, yeah,
Not
you're
really. I'm
not
not going
quite
to give
giving me
that.
that.
No.
Okay, fine, fine. Um, and
So
I'm
luckily,
not,
David,
yeah.
luckily, there are some very helpful bleeding assessment tools that you can use to direct your history taking. Okay, because we're hematologists, we don't want a full general medical history here. But what we do want to know is we want to assess basically what hemostatic challenges the patient has had during their life. Okay, because if someone has a bleeding disorder, then they're not going to have made it through childbirth or major surgery or dental extractions without having had some sort of major bleeding history. Okay, now one of the tools that I really recommend is the ISTH bleeding assessment tool, or the BAT. Okay, and it basically comprises of 14 different categories for thinking about kind of, well, basically hemostatic challenges, times where the patient might have bled. Okay, so it's things like oral cavity bleeding, hematuria, dental extraction, surgery, menorrhagia, postpartum hemorrhage. Have they got a history of joint bleeds, muscle hematomas, brain bleeding? And it's a really useful screening tool, and you can go through it bam, bam, bam really quickly. You know, there's one on MD Calc website, and you can quickly run through it with the patient, and it will give you a number which will then give you an indication as to whether this patient's likely to have a bleeding risk or not. Another quicker questionnaire is something called Heme which is another one that you can just quickly whip through, and it assesses whether the patient's likely to have a bleeding disorder. But that is your number one test, okay, is going to be your bleeding questionnaire, assessing the patient's response to hemostatic challenges. If you've got a young patient, obviously they might not have had the opportunity yet, other than delivery, to have come across bleeding challenges. And that's where your family history is also really important. So, in particular, your family history for haemophilia, for example. And I mean, do you think you can rely on it? Can you rely on the history for these patients?
No,
No. Yeah,
as House
exactly.
says, patients
No.
lie.
Yeah, no, you can't. Well, no, it's not really that so much, but the fact that you can get de novo mutations, and of course, you might have a mother that's a silent carrier. That's very common in haemophilia A and B because it's X-linked. And then von Willebrand's disease is often autosomal dominant, but it has variable penetrance, so it means you again can't rely upon a lack of history to mean that they don't necessarily have a bleeding disorder. So you've got your questionnaires, you've got your family history. And then the other thing I specifically asked for with my hematology hemostasis hat on is about liver disease. So alcohol intake, whether they've had any, liver problems, cirrhosis, varices, that kind of thing. Because we know liver disease is such a big problem in terms of causing bleeding. And then don't forget your other blood tests as well as your APTT and your PT. If you identify somebody that you think is at risk of bleeding, then don't forget your full blood count, because you need to know how many platelets they've got. And, do they have an underlying iron deficiency anemia that might give you a clue? Liver function tests, and your Klaus fibrinogen. Now, your Klaus fibrinogen, that's your building blocks as your fibrinogen. If you don't have enough fibrinogen in the first place, that's the end stage part of your clotting cascade. Then you're not going to be able to clot. It doesn't matter what's going on above it. So that can be a rate limiting step, for example, in things like DIC, where you just use up all your fibrinogen. So that's the best clotting test that you can do, is your history. And the reason why I then say that the PT and the APTT are definitely not useful outside of this clinical context is you can have a normal PT and APTT and yet have a bleeding disorder. Can you think of any that, you might have a normal blood test, but actually the patient's got a bleeding risk?
No, not offhand.
Okay, well, von Willebrand's disease.
Okay,
Your
yeah.
most common type 1 von Willebrand's disease probably isn't going to affect your APTT or your PT, because you've got enough factor 8 going around, and von Willebrand's factor isn't even being measured in this clotting cascade, because it's more something that's required for primary hemostasis. So you could take someone with von Willebrand's disease to theatre if you don't take a history and you do a clotting blood test screen. Other conditions are things like platelet functional disorders. So like there's lots of inherited platelet functional disorders that you can get. And then things like a factor 13 deficiency. So we haven't even, you're like, what's factor 13? Well, that's right off the side of the clotting cascade on that we've talked about. Factor 13 cross-links your fibrin when it's made. And so therefore it's not tested by the traditional clotting cascade. So you can again have a normal set of blood tests, but actually you've got a bleeding disorder. And then also, probably more commonly, is you get abnormal tests back when they don't have a bleeding risk. So can you think of any situations where that might be the case?
You've caught me a bit of a blank at the moment. I'll blame my baby brain at the moment.
Okay, that's fine. Well, it's things like having a lupus anticoagulant, like you talked about earlier.
Okay.
That
Yeah,
prolongs the
exactly.
APTT, and then you're going to have to do further investigations to prove it's a lupus. Meanwhile, that patient's operation is being delayed, so you're causing harm there. Likewise, in liver disease, yes, the patient is making less in the way of clotting factors, and so their APTT and PT are prolonged. However, their liver is also making less in the way of natural anticoagulants like protein C, protein S, and protein Z. Therefore, actually, both are going down, but our clotting tests are only measuring the clotting factors and therefore giving us this kind of skewed impression that these patients are at increased risk of bleeding, when actually they're also at increased risk of clotting. And it's just that they have less of each. And so the balance is kind of a bit more precarious. It doesn't take much to make a liver patient have a clot or have a bleeding event, but it doesn't mean that a prolonged PT and APTT necessarily mean that that patient is at significant bleeding risk. And they've shown things like platelet count and class fibrinogen level are more predictive of bleeding in a liver disease patient than the APTT and the INR, which is interesting. So again, you can have an abnormal screen, which then delays a patient's surgery and causes unnecessary worry, which doesn't mean the patient has a bleeding risk. So overall, these blood tests are not useful outside of the context of your bleeding history. And if you have a bleeding history, yes, you would go on to perform your clotting screen, even if that's a normal result. That's not going to reassure you. And you're going to need to then go on and do further tests like von Willebrand disease tests and platelet functional tests and aggregometry and things. So this is reflected in the NICE guidelines. So the NG45 is a really nice guideline that tells you what you should and shouldn't do before an operation. And it makes it very clear that in patients going for elective surgery, there is no role for doing a clotting screen. Unless the only exception they say is if you've got a patient that's got known liver disease, in which obviously you'll have to interpret it with caution, and with a high anaesthetic risk score. I don't really know what it means, but an ASA 3 or 4. So outside of that situation, we shouldn't be doing clotting screens on patients in operation. And what we should be doing more of is taking a really good bleeding history. So I think that's kind of most of what you need to know about a clotting screen. Do you have any questions about any of that, David?
No, I've actually come up with a bit of a scenario for you.
Okay.
And I thought what you might want to do or might like to do is if I kind of run through it, the same patient going through 3 different clotting tests, clotting screens,
Yeah.
and you can tell us how usul they are and how happy you would be to be phoned
That's
as the
fun.
haematology reg.
Yeah.
Okay. The 78-year-old lady, she presents to ED. She's short of breath, and in typical fashion, they stick a cannula in her, do a full set of bloods, including a clotting screen and a D-dimer.
Okay.
How useful is a clotting screen and a D-dimer in a lady who's presented short of breath? No other history provided.
Well, I presume that they're worried about a PE, but we have no information about whether infection is a risk here, and whether therefore we can't if they've got infection, other acute pathology going on, then the D-dimer is not going to be very useful. So I don't think that's a very useful test, and I'm not really sure why they've done a clotting screen, unless they're either worried about some sort of bleeding risk or they're about to start them on some sort of anticoagulant that needs monitoring. So I'm not sure. I would say that's not a very an example of not a very useful use of the clotting screen.
So the same lady then goes on to be found to have a pleural effusion that they think is infected. The pleural team says, we're going to tap this. And then they tell the little junior on the ward, usually me, I can't do it until I've got an INR.
Oh dear.
This lady's not on warfarin,
Hmm.
but they ask me for an INR and I do it and it comes back at say 1.6. And they go,
Okay.
oh dear, what am I supposed to do now? And they phone the hemorrhage.
Okay. Well, I mean, did you say the patient had an infection at this point? Have they had?
Yes,
Okay.
they got an
Yeah.
infected empyema.
I guess we could give them the benefit of the doubt and say that they're very worried that the patient might have an element of vitamin K deficiency. Maybe she looks malnourished or she's not been eating very well. Maybe she's a bit septic and they're worried for that reason.
So this procedure goes disastrously wrong. She has a hemothorax. She becomes hypovolemic and has an ischemic injury to her liver and kidneys.
Oh
She
dear.
appears septic and mottled, and she has a petechial rash. Do you think it would be useful to do a fibrinogen test?
Is this what they phoned to ask me?
Yes.
Okay, so I guess I hope they're going down the sort of DIC route here, and that they're worried about the patient's clotting profile and risk of DIC. So I mean, yes, I would do a Klaus fibrinogen, so not a derived fibrinogen because they're not very useful, but a proper Klaus fibrinogen. And I would be looking at the platelet count, and I would be looking at the APTT and the PT, and kind of getting a bit more of a history. And I think that is a useful use of the clotting screen. Yeah.
Okay, so one out of three, and I feel like, especially as a sort of, as a pretty junior doctor, is I get asked to do these quite a lot, and
Yeah.
often people come through the front door and they get a cannula and bloods, including
Mm,
a clotting screen, or
mm,
ask for an INR before a procedure's done, and it
yeah.
just sounds like it's a bit dogmatic and not actually particularly useful.
Yeah, I think that's a really nice case actually for demonstrating when it is and isn't very useful to do a clotting screen. And we probably are still doing way too many clotting screens compared to what we need to do. So it's about just thinking about what can it tell you and what other information can I get from other tests as well. But yeah, great. So shall we summarize, David?
Yes, if you want a
Okay.
golden nugget for us,
Yeah.
takeaways that you really think are important.
Well, I mean, my number one golden nugget is going to be your best clotting test is a history. Okay. So that's number one. I would say, and I really do promote using some of these questionnaires. They really are useful. I use them in the H&T clinic. And
I was going to say, can you just repeat the ones that you'll go to? Which one would you go
yeah,
to?
I use the ISTH BAT bleeding assessment tool. And also the heme stop one is pretty good as well.
Did you say that one was on MD Calc?
Yeah, the ISTH BAT definitely is. Do you want me to see if the
Okay.
heme stop one is? Let me just.
I feel like that's the thing I'll reach for when I'm like panicking and someone asks me for a number.
Oh, it's not. It's actually hem stop. So I'm glad you asked. It's not. I
Okay.
thought it was heme, but it's hem. It's an acronym for hematoma, E for the E in hemorrhage, M for menorrhagia, S for surgery, T for tooth extraction, O for obstetrics, and P for parents. So that's nice, actually. I like that, and
I like that.
I've heard that banded around, and that's on the Practical Hemostasis website. So
Great.
look that up. Yep. And then I would say the other golden nugget is, just go back to the basics of looking at the clotting cascade to work out what might be affecting your APTT or your PT. And then the third thing, I guess, to say is that don't forget that primary hemostasis is a thing and it's really important. So it's not just about the clotting cascade. You've got primary hemostasis where you get your primary platelet plug, and then secondary hemostasis, which actually requires your clotting cascade to make your thrombin to cross-link your platelets to make a nice, juicy, stronger secondary hemostatic plug.
Lovely.
Great. Okay, so next podcast we will talk about the actual nitty-gritty of doing clotting tests in the lab, what we call practical hemostasis, which is it might sound a bit boring, but it's actually very exciting. And
You may take some convincing. We'll,
no,
I'll
it
take your
really is.
enthusiasm.
Honestly, like you need to go to your lab and you need to get involved in doing some of these tests. And measure a PT and an APTT the old-fashioned way with a watch glass, and you'll realise it's really quite cool. So we're going to do that next time, and I hope this has been a useful introduction into clotting and the use of screening tests, when to do them and when not to do them.
Yep. Thanks very much. I look forward to your insights into the lab, which I feel like pretty inaccessible until probably you get to ST3.
Yeah. Okay, great. All right, well, it's lovely to see you again, David, and we'll catch up soon.
Yes, and you.
See you later. Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.